Welcome to our breakout session on healthy life expectancy and state pension age. I'm Natasha Hill. I work at the Government Actuaries Department in the central research team, also with a focus on mortality. I can help out client teams when they're helping their clients advise on demographic assumptions, especially mortality. So the people living longer in the UK, problem is good health, people living good health is trailing behind that, with people getting disabilities and ill health before they reach retirement age. So this is kind of raising important questions. Is if people are getting to state pension age and are already in ill health, should healthy life expectancy be considered when state pension age is reviewed? To guide us through these complex issues, we've got two expert speakers, Paul Nixon, from here at the Government Actuaries Department as well. He's going to start with an overview of the SPA review, how this happens, and he's been involved in advising on the SPA, Government Actuaries role on advising the SPA. This has happened in the past. Paul brings 25 years of experience in pensions and over a decade as a lead consultant on both private and public pension policy. He's led GAD's advice in the last two state pension age reviews. Following Paul, we're going to have Greg, who's joined us here from the Office for National Statistics. He's head of population health monitoring at the Office of National Statistics, and he leads the production of official statistics on health and mortality and has a strong track record in modelling analysis to inform public health and policy. He'll explain how a healthy life expectancy is measured, the challenges in interpreting and collecting the data, and the implications for demographic and mortality assumptions, which underlie both pension scheme valuations and the state pension age reviews. There should be some time for questions at the end. We're going to go the old-fashioned way with hands up because we've got a fairly small room, there are lots of people. So save you, but we've obviously be thinking of questions as we go through the talks, and hopefully about 10 minutes at the end for any questions. We are recording the session, but we will stop when the questions come on, so you can ask what you'd like. Thanks for joining us today, and I'll pass swiftly over to Paul.
Thank you. This is working. Right, good. Well, thanks. Good to see so many people in the room. We've just about squeezed you all in. I guess there's vested interest for all of us in this topic. We'd all like to live long, healthy lives, and we've probably all got an interest in when we're going to get our own state pension. So hope you find this an interesting session. So I'm going to start with a quick history lesson on state pension. So the first state pension was introduced in the Old Age Pensions Act in 1908. And it may surprise a lot of people actually when they hear what the state pension age was at that time that the first state pension was introduced, given where we are now, because at that time the first state pension age was 70, so older than we've ever got to since. And I think at the time the state pension was very much to protect those really poorest, vulnerable people in society. Now that reduced to age 65 in the 1920s. And then to 60 for women only in the 1940s, just after the war, which is when the first universal basic state pension was introduced. And then it stayed that way for the next 50 years or so, until gradually there was increasing pressure to equalise state pension between men and women due to various reasons, international comparisons, but primarily sex discrimination legislation, which impacted on private sector pensions as well in the 1990s. And this was finally announced in the budget in 1993 and then implemented through the 1995 Pensions Act. But implementation of this equalisation, and by that I mean the female state pension age was increased to 65 so that men and women had the same age. And implementation didn't start until 2010, so some 15 years later, and the timetable did change along the way. Now, there has been some criticism of this. I'm sure you're all aware of the acronym WASPI, Women Against State Pension Inequality. And there are various reasons behind this. And indeed, women born in 1953, for example, reached their state pension age in 5 different calendar years between 2015 and 2019, depending on when exactly in 1953 they were born. So you can understand why some people were a bit frustrated with the process, not only on that, but in terms of the amount of notice that people were given for when these state pension age changes were happening. And that's something that we can come on to later. The Pensions Act 2007 then started introducing increases in state pension age for both men and women, gradually from 65 up to 68 in various stages. And that timetable itself was subsequently amended in 2011 to accelerate some of those increases. And then the 2014 Pensions Act finally introduced periodic pension reviews of the state pension age, which required the government to look at various factors when setting state pension age, including life expectancy. And there have been reviews under this Pensions Act carried out in 2017 and most recently 2023. And this is where GAD fits into this process. So the Pensions Act itself requires 3 different reports to be produced whenever there is a state pension age review. One of these is done by the government actuary, which considers issues around life expectancy. I'll come on to the details of this more in a minute. So at the previous review in 2023, that was carried out by the government actuary at the time, the late Martin Clark, Fiona's predecessor. There is also an independent review, which has to consider other specified factors relevant to the review, is what the legislation says. So to make of that what you will. At the last review, this was carried out by Baroness Neville Rolfe, who you see on the screen there, who is a Conservative peer in the House of Lords. And then finally, the DWP Secretary of State has to do their own review. And again, the legislation is rather vague. It says that this review must have regard to life expectancy and other factors the Secretary of State considers relevant. That's what the primary legislation says. And at the last review, that was carried out by Mel Stride, who was the Secretary of State for Work and Pensions at the time. So the government actuaries review, and this is where I've been involved myself in the last 2 reviews. So the legislation and GAD's terms of reference specifically require us to carry out a number of prescribed calculations. The parameters and assumptions that we have to use for this review are specified by the government. They're not set by GAD. And this includes assumptions around life expectancy. Now, the primary calculations that we are required to produce in this review focus on the proportion of adult life that people spend in receipt of their state pension. The legislation itself doesn't specify what this proportion is. Now, at the time of the first review in 2017, DWP originally said that 1/3, so 33.33% was the target at that stage. For the most recent review in 2023, GAD were asked to look at proportions of 30, 31 and 32% when doing our calculations. Now, I must stress that this proportion of adult life applies to the population as a whole as an average. For each individual, it will obviously be very different depending on your own individual circumstances. So for someone who doesn't survive to reach their state pension age, you're going to have a proportion of 0. If you live to 100, it will be something over 40%. So the figures that we do in our calculations look at the whole UK population as a whole and average this out. The GAD report also considers various issues around life expectancy. So I mentioned our calculations have to use the ONS, Principal Population Projections, and these themselves are updated every 2 years. And the calculations that we do vary quite a lot at different successive sets of ONS population projections. Our reviews also consider other issues around life expectancy, so trends in the data, how this varies between different population subgroups. So, for example, by location, by socioeconomic status, there's wide variations in individual life expectancies within those groups. And issues around health. And Greg later on is going to talk around healthy life expectancy and the way that can impact on this review. So at the 2023 review, the GAD report outlined the results of some of our calculations. And these are primarily framed around when the increase in state pension age from where it is at the moment, from 66 up to 67 and 68 and beyond. The calculations look at what years those increases would have to take place in order to maintain these particular proportions of adult life in retirement that we've been asked to consider. And the results up here that you can see also compare this to current legislation. So at the moment, the legislation provides for state pension age to increase from 66 to 67 in the mid to late 2020s. And then there's a further increase to age 68 in the mid 2040s. That's what legislation says at the moment. After the 2017 state pension age review, the government said that at the time their policy was to bring forward that increase from 67 to 68 to the late 2030s, as you can see there. That at the time was based upon a proportion of around 32% at that time. What the results from our most recent review show is that based on the latest ONS projections that were used in 2023, maintaining that same kind of proportion of 32% would have actually pushed out when you need the state pension age to increase from 67 to 68 to maintain a 32% proportion. And actually it was something closer to 31% that at that time would have been more equivalent to somewhere in between what the legislation says and the government policy. But one thing I think it's very important to stress is that the results of GAD's calculations set out in our report do not directly impact on the state pension age timetables. These are still a matter for the government to decide following looking at the GAD review, the independent review, and, as the legislation says, any other factors considered relevant. And there are an awful lot of other factors that are relevant. We've got lots of these on the slide at the moment. There are clearly much wider issues here at stake than just the calculations that GAD do in our report. Some of these are considered in our review. Life expectancy, you'll see, is one issue that feeds into this, as is healthy life expectancy, which appears up there somewhere. But as you can see, there are much wider issues, and many of these were considered in the independent review carried out by Baroness Neville Rolfe, which has a much broader terms of reference than the GAD review. And I think most importantly, cost is a huge consideration for the government when setting state pension age policy. Siobhan in the first talk earlier mentioned how there's an ageing population, and increasingly over the next decades we're expecting a much higher number of pensioners to working age people as the baby boom generation comes through and reaches their retirement age, and we have lower birth rates in the population that followed that. And indeed, the analysis at the last state pension age review pointed that at the moment, the spend from the government on state pensions is around 5% of GDP at the time of the last review. If you project that out over the next 50 years and nothing else changes in terms of state pension policy, then by the 2070s, we expect that proportion to have increased from 5% of GDP to 8%. And you can see something's got to give there, whether that means increased taxes, national insurance, or changes in state pension policy, be it that state pension age itself or the level that state pension age is set. Because the triple lock policy, for example, is one component of how that will change over the years. So the DWP report following the last review, the main conclusion from that was that the increase in state pension age from 66 to 67 was still going to go ahead in the mid to late 2020s, so that's about to start next year. But the increase from 67 to 68, the government did nothing following that review other than to say, we will review this again within 2 years of the next Parliament. Now, we're already 1 year in, so we can expect that the next review will happen sooner rather than later. The government haven't said anything formally about the next review yet. But one thing also to note, and this comes back to the WASPI issue that I mentioned previously, is that what the government did say at that time was that any changes to state pension age timetables will give people at least 10 years notice of when their state pension age will change. Now, as I said, at the moment, legislation doesn't increase state pension age from 67 to 68 until the mid 2040s, but there is scope for that to be moved forward to sometime in the 2030s albeit if the government's going to stick to this principle of 10 years notice, then there's clearly a limit to which that change can actually be made. So there's various aspects that might be considered at the next review, and this is going to lead on to the next talk from Greg around healthy life expectancy and the issue, the extent to which that can be used to assess things like state pension age review, and this may be something that will be considered in more detail at the next review. I'm now going to hand on over to Greg, who's going to talk in a lot more detail about healthy life expectancy itself.
Thank you, Paul, and thank you very much for having me. I won't go into too much detail about healthy life expectancy given the time, but I can talk to you about a lot of different aspects of it in questions afterwards or in the break as well. But yes, hello, thank you again for having me. Natasha mentioned I'm head of population health monitoring. This means that my teams and I are the bearer of all the bad news that was mentioned about population stats earlier, covering births and the falling birth rate, mortality and life expectancy, and what this means for how ONS stats are used in pension age reviews. So today I'm going to talk about how we calculate life expectancy, how we calculate some similar measures with a particular focus on healthy life expectancy, or HLE, and then the challenges that calculating HLE faces both now and into the future, what we can do to overcome those, and overall the implications of using these measures that are adding complexity and nuance to life expectancy when thinking about the topic of state pension age, and how these different measures can be used there, what difference it would make to use different ones. So to start with, how do we measure life expectancy? Well, ONS gets every death registration and death certificate from that's produced in England and Wales and processes these into our deaths data. It's a legal requirement to register a death. This doesn't mean that it always happens, and it doesn't mean it always happens quickly, but it does mean that we broadly consider that we have close enough to 100% coverage of deaths in England and Wales in our data. And these death certificates provide the date of birth of the deceased and the date of death. And this allows us to work out something called a life table, which many of you might be familiar with, so I won't spend too long on this, but the idea is that for a given age, we know the probability that someone would live to the next year of life at a given time. So we can expect that with life expectancy changing over time, depending on when you look at the data, the probability of a 60-year-old living to 61 could be different now to how it was 20 years ago. And you can look at these across someone's life to see their likelihood of living to different ages. And that's how we calculate life expectancy for different combinations of age, sex, and part of the country, especially local authority level. We present our stats as life expectancy at birth and life expectancy at age 65, which is broadly aiming to present the years of expected life after retirement, though as Paul's just said, the actual age of retirement is changing over time and uncertain into the future. But those aren't the only ages that we can produce this stat for. So life expectancy at age 30 has been used in the past to be a policy evaluation marker for the health of the working age population. So life expectancy is one thing. How do we calculate healthy life expectancy? Well, we get those death certificates again and everything we knew about the person that we've put into the life tables, and we combine this with survey data. In our case, we use the annual population survey, or APS. This is a continuous household survey covering all of the UK, and it uses data from the labour force survey, which hopefully doesn't make too many of you wince, given the labour force survey has not had particularly good press recently. But the APS has the largest coverage of any UK household survey, and therefore, compared to other surveys, it allows generation of stats for quite small geographies like local authority. We use a specific survey question from the APS, which asks, how would you rate your health in general? Would you say it was very good, good, fair, bad, or very bad? And we are looking to estimate the prevalence of the population for each combination of age, sex, and geography that would consider their health good or very good. And then this is combined with the life expectancy information we have to have a measure of how many years of life people could expect to live in good health versus how many years of life we could expect to live in not good health. This is quite a static measure. So if we had, for example, a person who, what's a good way of describing this? I guess if your healthy life expectancy was 65 and you responded to the survey saying that you were in good health at 65, but in poor health at 66, this measure now assumes that you were in poor health for the rest of your life. And if you said you were in good health, it assumes you've been in good health up to this point in your life. So it could be that actually you're going through a short-term experience of poor health that you will recover from. And so it's quite difficult that healthy life expectancy is quite a static measure. The idea is that once you start being in poor health and living years in poor health, you aren't returning to good health. But at the same time, it adds an important subjective element to life expectancy, because, as I'll say more about later, even if your life expectancy is such that we expect 30% of our adult life to be lived at pension age, if actually we expected that all of those years weren't in good health, that becomes a bit more of a sobering statistic if you realize that all of your years in good health are years you spend working. Healthy life expectancy is not the only way to add this sort of health nuance to life expectancy. There are a couple of other stats, and ONS publishes on them. As you can see, that's our Health State Life Expectancy publication on the right there. One of these is disability-free life expectancy, or DFLE. This is very similar in its construction to healthy life expectancy, but instead of asking about your self-perceived health with the question I mentioned earlier, it asks a question that is consistent with the Equality Act definition of disability. So looking at to what extent do you feel any conditions or impairments you have affect your ability to conduct your day-to-day life. And if you say that your conditions or disabilities impact your life a little or a lot, you're considered to have a disability. Similarly, health span, stylized in big capitals by NHS England, who produce it. It's not in capitals because it's a particular preference here. That's just their way of presenting it. Is an admin data statistic using NHS records, which records your life up to when you first experience a long-term, a significant long-term condition, NHS England put it. Both of these measures give you some sense of years in good health and then later years in not good health. They have that same static issue I mentioned for healthy life expectancy. And they compare interestingly with HLE. So disability-free life expectancy is broadly similar to healthy life expectancy. It's generally a bit more pessimistic, and you have 1 to 5 fewer years of good health, depending on your sex and whereabouts in the country you are. Health span is a lot more pessimistic. And this is because it could be that you're actually diagnosed early with a condition which is then treatable and you experience more of your life in good health, or manageable in a way where actually this condition isn't going to be debilitating to you for several years yet. So that's why health span generally estimates you will live less of your life in good health. And finally, the Charlson Comorbidity Index is quite a different one. This gives you a number based on your age and the conditions you have and your risk of surviving with them for the next 10 years. So the more conditions you have, the higher your number. Certain conditions are given different numbers as well, based on their risk of death. And this is something which we can calculate using death certificates, because every condition it includes is mentioned on a death certificate. So we can use that excellent data I mentioned earlier to calculate something here. It doesn't have a subjective element of your self-perceived health, but it is subjective based on the numbers it has assigned different conditions. And it was made in the 80s. And as a product of that, it says that AIDS is the condition with the very highest risk of dying, where it doesn't account for the fact that we've got much better medication and treatments to support people living with AIDS now. So again, it has a subjective element, but not in the same way as the other conditions. So I've mentioned healthy life expectancy and how it differs from these other measures, but how does it differ from life expectancy? Well, on this chart, that full line, the green plus pink, Yeah, it's readable on that screen. Shows us your life expectancy for each region of England and then Wales. The left chart is males and the right chart is females. And the green line is just your healthy life expectancy. There are some interesting general trends here. One is that there's quite a big difference between your life expectancy and your healthy life expectancy. That pink bit is on average how many years you will live in poor health, estimated using HLE. And in general, we can also see that there are regional differences in life expectancy, as we know from that, but also regional differences in healthy life expectancy, which are broadly consistent. But healthy life expectancy is more similar between the sexes than life expectancy is. Typically, we think that women will live longer, but actually many of those additional years will be in worse health, as estimated by healthy life expectancy. One interesting sobering thought I mentioned earlier, the idea that maybe we wouldn't spend much of our pensionable age life in good health. We see that when looking across the two sexes and across these regions, the region where on average you could expect the most years of healthy life is London for men, Southeast for women. And for women in the Southeast, it's 64.4 years of healthy life expectancy from birth. And that means that at present, with the current state pension ages, healthy life expectancy would estimate that on average, people wouldn't spend any of their years of pensionable life in good health, which is a bit of a sobering thought. However, I've mentioned HLE is not the perfect stat, and so don't be too disheartened by that stat because other statistics will differ. But there are also challenges in calculating healthy life expectancy. As I mentioned, it's based on survey data for the health element, and the number of respondents or the achieved sample of the annual population survey has been declining in recent years. And this is true across many large surveys. And again, something you've probably seen in the news about the labour force survey and ONS's economic stats as a result. The APS has guidance on how large a sample you need for each of your subcategories, in our case, that combo of age, sex, and geography, in order to robustly estimate something from it. And for us, we see that if you look at some of the age groups with worse response rates already in the APS, such as young men aged 16 to 19 is a particularly influential age group in our calculation. Back in the 2011 to 2013 survey results, for all geographies at that age, we only had 2.7% of local areas that weren't achieving APS's desired sample size for using it for analysis. In our latest data looking at 2020 to 2022, that's now over a third of local areas don't reach that ideal sample size for producing robust results. And while we can do things like present confidence intervals, expanding over time to give people a sense of uncertainty, we don't have much sense that the public fully understand what that really means. And a lot of our calculations still need to use central estimates. So results are getting less robust. We've taken steps to overcome this. And when you get the slides after this session, you'll be able to click the link in that first line to view our methodology article to look at this in a bit more detail. But these are two charts from that methodology article. Our objective is to model the survey data in some way to smooth it out and get rid of some of the volatility that we're seeing from these small sample sizes, especially where if you are in an area where generally your healthy life expectancy estimate was particularly high or particularly low, if your results are getting more volatile, that could become extremely high or extremely low and give us false information about the range of HLE across society. And what we see is, especially for the oldest age groups where there aren't so many people, we see some quite extreme results. And the youngest age groups where we don't get the same sample size from survey response, we see some quite extreme results. So again, without going into too much detail about what we're doing here, I'll say logistic regression modeling for those who are interested, but I can say more later if you like. We see that one of these lines is what we got from just the survey data. One of these lines is if we try to interpolate using the census, which also asks about health, which hopefully you all know about from completing the census like good people. But then we have our logistic regression modeling for estimating people's or the rate of good health in different areas from regional differences we see if we aren't able to produce it for local areas individually. And we see that, to speak very broadly, our estimate is between the interpolated census and the raw data. It's the light blue line on this chart. You probably don't think these lines are that different, and that is a good thing. We want our results to broadly look similar to what we were producing before, or our model estimate isn't doing something good. We just wanted to bring these extreme results more in line. And generally, we see that using our modeled approach, the range of HLE to LE, HLE highest results and HLE lowest, or most and least years in good health, has been reduced as a result of making these changes, but also the ranks of local authorities are broadly retained. I think it's something like the top 20 highest HLE areas are, I think 14 of those are consistent before and after, when you rank before and after doing our modelling, and 13 are consistent of the bottom 20 before and after doing our modelling. And the others have, no one has changed rank by a particularly large amount. This isn't perfect, given we're only modelling some groups and survey samples appear to continue to decline. So what do we do next? And we're looking into this right now. We could try using other survey data. We could just continue with modelling, but more of these age, sex, geography categories. But as samples decline, even our modelled approach is going to become less robust. We could try using different surveys. As I mentioned, the APS is the largest household survey, but we could always ask the same questions in other surveys, like ONS's Health Insight Survey, which has quite a big sample because it's based on the COVID infection survey, and then combine them in some way. But then we'd need to take account of any biases those surveys have in how representative they are of people. So it all gets a bit more complex. There are admin data possibilities, as I mentioned HealthSpan earlier, that NHS England produce, but ONS also owns the public health data asset, which is a unique tool we have, which is excellent. It combines census data, our birth and death registrations, health data from places like hospital episode statistics, and benefits data from DWP, and work and tax data from HMRC to give us a really rich record level linked data set into the population. What it doesn't have is any sort of self-perceived health, because there isn't an admin source which gets that. So we can look into trying to do something with admin data that is a very good correlator with healthy life expectancy. But then we reach some philosophical questions about, are we still measuring healthy life expectancy? Is this something that the public can understand enough to accept in the same way that healthy life expectancy is broadly quite an accepted measure, or challenge if they want to analyze it themselves, and only ONS has access to this data, which puts us in a bit of a difficult position. And as I mentioned earlier, we've got things like HLE and DFLE and different ways of describing things, all sorts of acronyms, as many as you'd like. And these don't have to be exclusive. We could average across multiple metrics and see what we do next. But this is quite an open question for us at the moment of how do we improve our methods to capture something like HLE that's useful into the future. A while ago, I received my 5 minutes to go prompt, so I will be really quick on this bit. What are the implications of us doing this? What does this all mean? What difference does it make? Life expectancy is really useful for calculations such as thinking about state pension age review. It is objective on its own, but it doesn't tell us about this quality of life. And if we're expecting 30% of our adult life to be of pensionable age, are we going to be in good enough health to enjoy it? And this is where these sorts of stats come into their own. If you think about that HLE stat of probably not living much of your pensionable age in healthy life, working state pension age does become a less attractive option. But realistically, there are many people who don't have the option of stopping work earlier. So as far as how much people can act upon this information, it's more limited in that sense. And the subjectivity of adding things like self-perceived health can limit the interpretability, especially when you start trying to average across the population and saying, having a stat for every person who's male and aged 60 to 65 in one local authority, there could still be huge differences in that area. But this is likely a reason that there are these different measures. And originally I put competing measures, but that doesn't have to be the case. As I said, you could average across disability-free life expectancy, health span, something similar, to get something more robust into the future. So the fact that our survey sample sizes are falling doesn't mean that these type of measures are a lost cause. And finally, I've got a couple of questions on here about what would make a future measure useful to you, which you may not have the answer right now. But as we're starting to think about what we could do instead of HLE into the future, it would be great to get people's views, and we will run things like consultations to understand if we are developing a successor statistic, what would that need to do in order to still be useful to people? Thank you. I'll just pause with those slides, with those questions on screen for you to mull over.